So I want you to imagine, if you will, a teenager.
Okay.
A teenager going through a really massive, rapid, and just incredibly awkward growth spurt.
Right, we've all been there.
Exactly. And almost overnight, their economic bones, so to speak, are elongating. They're shooting up in height, gaining this incredible strength.
Gaining capacity.
Yeah, capacity. Entering the global stage with this newly found, undeniable capability.
Yeah.
But, and here's the glaring, uncomfortable problem.
Their clothes don't fit.
Exactly. Their health system clothes no longer fit. The sleeves are riding up past their forearms. The seams are literally tearing at the shoulders.
The fabric itself is just fundamentally unsuited for this
Right.
complex adult body they suddenly inhabit.
Right. So they are caught in this bizarre, paradoxical in-between phase. On one hand, they're still dealing with the residual risks of childhood.
The infectious diseases of poverty.
Right? Malnutrition. The fact that they still might not have perfect basic sanitation. But simultaneously, because of this rapid growth, they're suddenly staring down the complex, heavy burdens of adulthood.
We're talking chronic, non-communicable diseases.
Severe urban pollution.
The intense stress of a highly competitive global market.
Exactly. So let's unpack this, because this isn't just some clever metaphor for adolescence, is it?
No, this is the exact precarious reality for middle-income countries today.
Welcome to our deep dive. Our mission today is to conduct a really thorough conceptual exploration of how public health evolves.
And sometimes completely fractures.
Yeah, fractures during rapid economic transition. And I want to explicitly remind you, the listener, that this deep dive is a companion to your active reading of Chapter 1.4 of the Oxford Textbook of Global Public Health.
Right, whether you're a medical student, a junior doctor, a public health trainee.
Or an allied health professional.
Yeah.
You already know the basics. Our goal today is not to just regurgitate facts or read a syllabus at you.
That would be incredibly boring.
Very boring. We want to build clear conceptual frameworks. We're going to move systematically from risk to exposure to outcome and finally to system impact.
To really help you understand the foundational why behind public health decisions in these rapidly shifting environments.
Precisely.
And as we dive into this, I really want you to listen specifically for the paradoxes of transition.
There are so many.
What's truly fascinating here, and what often trips up policymakers, is how economic development alone absolutely does not guarantee health equity.
Right.
In fact, if you look closely at the data we'll be discussing today, you'll see how prosperity, if it occurs without deliberate anticipatory policy.
It can actually amplify disparity.
Exactly. It is a very dangerous assumption that more money automatically equals better health for everyone.
Yeah.
So today, we'll be reinforcing pattern recognition, systems thinking, and integrating epidemiology with governance and policy dilemmas.
So keep asking yourself, how do shifting demographics and global trade policies directly alter the clinical realities on the ground?
Right. For a physician running a rural clinic or a nurse managing an overcrowded urban ER.
So to kick things off, we really need to talk about definitions.
We do.
Because the lines distinguishing an emerging economy from a developing one are intensely blurred.
Very blurry.
Let's look at the World Bank classifications. They rely on gross national income, or GNI, per capita.
And they update these brackets every year using purchasing power parities.
Right, PPP. So in the historical brackets we're examining, lower middle income sits roughly between $1,000 to $4,000.
And upper middle income stretches from about $4,000 up to $12,500.
Anything above that is high income.
Right.
But here's my issue with this. These are just arbitrary financial thresholds.
Completely arbitrary.
A country doesn't magically transform its public health infrastructure the day its GNI per capita ticks over from $4,035 to $4,036.
No, of course not.
The literature uses terms like emerging economies very loosely, but it has to mean more than just hitting a specific dollar amount, right?
It absolutely does, and that's a crucial distinction. What exactly makes an economy emerging?
Right.
The CPII definition provides a much more robust framework than just looking at a GDP spreadsheet.
Okay, break that down for us.
An emerging economy entails vital ingredients of political economy. These are countries that have actively pursued economic liberalization,
Okay.
promoted a market orientation, and deliberately opened themselves up to international flows of goods, services, and capital.
But crucially, this process is associated with the active building up of institutions and strong state regulation.
Exactly. It's a managed integration into the global market, not just a chaotic free-for-all.
Think of the BRICS, Brazil, Russia, India, and China.
Or the expanded BRICS acronym that adds Indonesia and South Africa.
Right, these are the heady hitters, the massive non-OECD economies rapidly integrating into world markets.
And when you look at the macroeconomic data for those nations, you see GNI absolutely soaring.
Soaring. And as a result, the Human Development Index, the HDI, is going up.
Right.
Now, we know HDI is a composite index. It combines life expectancy at birth, educational attainment, and GNI per capita.
So HDI goes up, the politicians celebrate, it looks fantastic on paper.
But then you look at the Gini index,
Ah, yes.
which measures income inequality
Yeah.
and the poverty headcount ratios. I have to push back on this narrative of universal progress.
Go for it.
How can a country be classified as an upper middle income nation, boast a rising HDI, but still have staggering million-strong populations living below the $2 a day poverty line?
It seems entirely contradictory.
It does.
It seems contradictory until you differentiate between wealth creation and wealth distribution.
Okay, wealth creation versus distribution.
Right. The Gini index measures inequality on a scale where 0 is perfect equality and 100 is maximal inequality.
Yep.
Let's look at the reality of South Africa. You have a relatively high GNI per capita, historically sitting over $10,000 in purchasing power parity.
Which sounds great.
It does. But its Gini index is aggressively high, in the low 60s. And historically, over 30% of the population has lived on less than $2 a day.
Wow. And Brazil shows a similar pattern, right?
Yeah.
With the Gini hovering in the mid-50s.
Exactly. What this tells us clinically and epidemiologically is that national averages are essentially a statistical lie that hides local realities.
A statistical lie. That's a great way to put it.
Yeah.
A rising HDI might just mean that the urban elite in Sao Paulo or Johannesburg are living to 85.
Attending elite universities, accessing world-class private healthcare.
Exactly. While a few hours away, the rural poor are still dying of entirely preventable infectious diseases.
Wealth is highly concentrated.
Highly. So the defining characteristic of a middle-income country isn't just its average wealth.
No.
It's its extreme internal duality. It's a nation caught in a tug of war, undergoing a rapid, highly uneven transition.
Which brings us to the core assumption we really need to dismantle.
Which is
the idea that if a nation's overall income rises, the health of its population automatically and linearly improves.
oh, right, the straight line myth.
Exactly. If we look at the East Asian miracle of the 1980s, Hong Kong, South Korea, Singapore, Taiwan, and the subsequent explosive growth of China and India, we see unprecedented economic expansion.
Emerging Asian economies were growing at more than double the global rate.
But the relationship between this rising per capita income and health indicators like life expectancy and infant mortality is not a straight 45-degree line.
It's distinctly nonlinear.
Very nonlinear.
Let's really hammer this concept home, because this nonlinear curve is one of the most vital frameworks to master.
Absolutely.
There's a critical threshold you need to pay attention to, approximately $4,000 per capita income in purchasing power parity.
Right, the $4,000 mark.
Below that mark, the relationship between income and health is incredibly steep, highly responsive.
If you're a low-income nation, tiny incremental bumps in national income yield massive, dramatic gains in life expectancy.
And sharp drops in infant mortality.
Exactly. Why? Because you are buying the absolute low-hanging fruit of public health.
Clean water initiatives.
Basic sanitation, caloric sufficiency, foundational childhood vaccines.
You're preventing mass deaths from diarrheal diseases and basic respiratory infections. It is incredibly cheap to save a life at this stage.
But once you cross that $4,000 threshold,
the rules of public health fundamentally break.
they do. The curve flattens out entirely. The correlation is still technically positive, but you need exponentially more money to buy a single extra year of life expectancy for your population.
Because you're no longer buying soap and basic pipes and mosquito nets.
Exactly. To move the needle now, you're having to buy MRI machines,
Build specialized oncology wings.
staff cardiac intensive care units, and fund the lifelong pharmacological management of diabetes and hypertension.
The cost of intervention per quality-adjusted life year just skyrockets.
It really does.
Which raises an interesting philosophical and economic question.
Okay.
The classic assumption is always, wealth leads to health.
Right. A country gets rich, builds hospitals, people live longer.
But doesn't this run both ways? I mean, if you just look at the empirical econometric studies like the Bargava or Jamison studies, They completely flips this narrative.
They do. Jameson demonstrated that health improvements are directly correlated to a measurable gain in the annual economic growth rate.
It's something like a 0.2% gain in economic growth tied to health expenditure, right?
It is. It runs both ways. And understanding that bidirectional framework is a profound paradigm shift for policymakers.
Because historically, finance ministries in developing nations viewed health ministries as massive sinks for capital.
Basically, a charitable, necessary drain on the national budget.
Right, like we'll fund the hospitals with whatever's left over after we build the roads and the factories.
Exactly. But the data proves that health spending is actually an upstream economic engine.
An upstream economic engine.
Think about it. Imagine a factory assembly line. If your workforce is constantly decimated by malaria outbreaks, or if workers are taking weeks off to care for children with preventable diarrheal diseases,
Economic output plummets.
it plummets. A healthy population has lower absenteeism. Furthermore, early childhood interventions lead to higher cognitive development.
Which translates into a more skilled, competitive workforce decades later.
And critically, healthy populations don't spend their entire generational savings on catastrophic out-of-pocket medical costs.
They save capital. They invest.
Health is a fundamental prerequisite for sustained economic growth, not just a pleasant byproduct of it.
That upstream economic engine relies entirely on the people doing the work, which means we really have to look at the mechanics of the population itself.
Demographics.
Right. As an economy transitions, its demographic structure fundamentally alters. Now, we all know the standard demographic transition model.
High birth and death rates eventually giving way to the low, stable rates and aging populations of fully industrialized nations.
We don't need to rehash the basic 4 stages.
No.
But the fascinating part for middle-income countries is that volatile, unpredictable middle zone.
Where mortality has dropped, but fertility is just starting to decline.
Exactly. This creates a massive temporary bulge of working-age adults.
This is the demographic dividend, or the demographic bonus.
To understand the sheer mathematical leverage of the demographic dividend, we have to look at the dependency ratio.
Right. This is the proportion of the population that is economically dependent. Children under 15 and the elderly over 65, compared to the economically productive adult population aged 15 to 64.
When an emerging economy hits this middle phase, there is a golden fleeting window.
Because birth rates have finally started to drop, there are suddenly fewer dependent children needing food, schooling, and pediatric care.
And because the population hasn't fully aged yet, there are very few dependent elderly needing chronic care or pensions.
Look at the Asian Development Bank data. The dependency ratio in that region plummeted from 78% in 1975 to 56% in the year 2000.
And is projected to drop even further.
Exactly.
It's basically a temporary cheat code for economic growth.
The cheat code, I like
You
that.
suddenly have this massive, economically productive workforce. And because they aren't spending all their resources supporting huge numbers of dependents, capital is suddenly freed up across the entire society.
Families can save money, governments can collect massive amounts of tax revenue.
And that money can be aggressively invested in infrastructure, higher education, and further economic expansion.
This was the exact engine behind the East Asian miracle in places like South Korea and Singapore.
And it's what has been driving countries like Thailand, Malaysia, Indonesia, and the Philippines.
But, and this is a massive but,
There is a ticking clock on this dividend. It expires.
it absolutely expires. And this is where anticipatory governance becomes critical. The demographic window eventually closes because that massive bulge of working-age adults will inevitably age into the 65 and older bracket.
And because the fertility rates remained low during that boom period, there's a much smaller cohort of young people coming up behind them to replace them in the workforce.
Without that high fertility replacement, the old-age dependency ratio skyrockets.
The public health infrastructure that was built to support a young, resilient workforce suddenly finds itself buckling.
Buckling under the weight of a massive elderly population requiring complex chronic care.
All while the tax base of young workers is actively shrinking.
If a middle-income country does not aggressively build its healthcare infrastructure and pension systems during the dividend years, they face economic stagnation and a healthcare crisis as they age.
So while this massive workforce is in its prime, it naturally drives countries to integrate heavily into the global market.
They want to export, they want foreign investment.
The International Monetary Fund lists the standard ingredients for these transition economies: liberalization, macroeconomic stabilization, restructuring and privatization, and institutional reforms.
This global integration brings huge opportunities. Rapid technology transfer, better global coordination.
But let's be real, it's a massive double-edged sword for public health, especially when we start looking at international trade agreements like TRIPS and GATS.
Yes.
Let's start with TRIPS, the Trade-Related Intellectual Property Rights Agreement. I know proponents argue this is essential for innovation, but the reality on the ground in middle-income countries seems devastating.
It is a profound policy dilemma. TRIPS is a World Trade Organization agreement that requires member nations to strictly protect intellectual property, and that includes pharmaceutical patents.
The argument from the pharmaceutical industry and high-income nations is that strong patent protection is absolutely essential to spur research and development.
Right. The logic is that without a guaranteed period of market exclusivity to recoup costs, companies simply wouldn't invest the billions of dollars required to invent a new cancer drug or a novel antibiotic.
Which, sure, makes sense from a business standpoint.
However, from a global public health perspective, TRIPS creates a severe systemic friction. It heavily restricts a nation's ability to manufacture or import affordable generic versions of life-saving medicines while those patents are active.
And middle-income countries are caught right in the crosshairs of this debate.
They are.
The least developed countries, or LDCs, often get general exemptions from TRIPS.
Aren't there granted leeway to bypass some patents for public health emergencies?
But middle-income countries, even though they have tens of millions of people living in crushing poverty, they do not get those blanket exemptions.
No, they're forced to bear the full brunt of patent enforcement.
Look at what happened in Argentina. A study estimated that introducing strict product patents there would cause a 270% price jump for essential medicines.
Which is astronomical.
That would lead to a 45.5% drop in medicine consumption. Can you imagine the clinical fallout of half your patient population suddenly unable to afford their medication?
It was estimated to create an increased annual expenditure of nearly $200 million.
Another broader analysis spanning Argentina, Brazil, Taiwan, India, Mexico, and South Korea estimated welfare losses in the billions of dollars.
I get that pharma needs to recoup R&D, but this is effectively a death sentence for someone earning $2 a day.
The most historically significant and tragic example of this tension is the chilling effect TRIPS initially had on access to antiretroviral drugs, or ARVs, for HIV/AIDS.
In the late 90s and early 2000s, patented ARVs cost upwards of $10,000 to $15,000 per patient per year.
That was an impossible astronomical sum for health systems in emerging economies.
Particularly in sub-Saharan Africa, where the epidemic was exploding. Millions died because the drugs existed but were legally and financially inaccessible.
It wasn't until generic manufacturers in middle-income countries like India, who are actively navigating and sometimes challenging complex legal frameworks regarding TRIPS.
Until they began aggressively producing generic ARVs for a fraction of the cost, eventually dropping it to around $1 a day, that the global tide against HIV/AIDS truly began to turn.
It is a stark reminder that trade policy is health policy.
But it's not just physical medicines being traded. The General Agreement on Trade in Services, or GATS, turns healthcare itself into a globally traded commodity.
This absolutely fascinates me from a systems perspective because the risks are so subtle but so damaging.
GATS can facilitate good things, like cross-border telemedicine or foreign investment in building new hospitals.
But it also drastically accelerates the brain drain.
Yes.
If healthcare is a globally traded service, highly trained nurses and doctors who are often educated at public universities, subsidized by the taxpayers of a middle-income country.
They are heavily incentivized to migrate to high-income countries for better pay.
Or, even if they stay in their home country, they leave the public hospital system to cater exclusively to wealthy medical tourists in private state-of-the-art urban clinics.
It causes a massive, localized misallocation of health resources. You're basically exporting your best clinical talent while your rural clinics collapse.
And we must also look at trade liberalization in an even broader sense, specifically the Uruguay round of trade negotiations, which drastically lowered tariffs and opened borders.
This liberalization allowed transnational corporations to aggressively enter emerging markets. And it wasn't just benevolent companies.
No, it was industries directly detrimental to public health. The history of the tobacco industry is the perfect case study here.
Facing declining sales, massive public health campaigns, and tighter regulations in industrialized, high-income nations, major tobacco companies realized they needed new consumers.
So they explicitly targeted the growing, newly liberalized, and far less regulated markets of Latin America in the 1960s.
And the newly industrialized economies of Asia, like Taiwan, South Korea, and Thailand in the 1980s.
Trade liberalization directly facilitated the export of behavioral risk factors. It profoundly and intentionally shifted the epidemiological landscape of these nations toward lung cancer and cardiovascular disease.
Which perfectly transitions us, or rather forces us to ask, where are all these newly targeted consumers actually living?
We have this massive young workforce driving global trade, but that raises a physical question. Where are all these people working and sleeping?
They aren't staying on rural agriculture farms.
No, they are flocking to cities, which creates our next massive public health blind spot: population density and urban agglomeration.
Let's acknowledge the sheer scale first. We're dealing with demographic giants. China, India, Indonesia, Brazil.
Together, they account for nearly 3 billion people.
But as we discussed, they're all moving at completely different speeds. We have to differentiate between the mortality transition and the fertility transition.
Because pattern recognition tells us they rarely happen simultaneously.
Precisely. The transition from high to low death rates almost always precedes the transition from high to low birth rates. But the gap between those two events dictates the unique health profile of a nation.
Let's contrast three very different national profiles to illustrate why a one-size-fits-all policy fails. Look at Jordan.
Okay, Jordan.
It has successfully driven down its crude death rate to very low levels, but its crude birth rate remains incredibly high.
It's a rapidly growing, overwhelmingly young population, with a massive percentage under the age of 15.
So the health system there, the budget, the infrastructure must be heavily geared towards maternal, neonatal, and pediatric care. Building a massive network of geriatric memory care facilities in Jordan right now would be a misallocation of resources.
But then you look at Russia, which is a complete tragic outlier.
Russia is far along in its fertility transition. It has a very low birth rate.
But it suffered an anomalous, catastrophic mortality crisis.
Following the economic and political collapse of the Soviet Union in the early 90s, the social safety net dissolved. Russia's life expectancy plummeted backwards to 1960s levels.
It dropped below 69 years.
And this wasn't driven by a new virus. It was driven by the societal trauma of transition. Stress-related risk behaviors exploded. Massive rates of alcoholism, alongside a surge in violent deaths, suicides, and traffic accidents.
It's a stark reminder that transition can be violently destructive to health.
And then you have South Africa, where life expectancy also plummeted down to 52 years, well below its previous peak.
But this was driven almost entirely by the infectious disease burden of the unmitigated HIV/AIDS epidemic.
These contrasting profiles prove that economic transition is not a neat, predetermined path on a graph. It is chaotic.
But one truly universal trend across almost all these transitioning nations is the sheer velocity of urbanization and the rise of the megacity.
A megacity is defined as an urban agglomeration of over 10 million inhabitants.
The projections suggest there will be nearly 40 megacities globally in the near future.
In public health terms, we cannot just view megacities as large towns. We must conceptualize them as risk magnifiers.
The unprecedented density and interconnectedness mean that any localized failure, whether it's a breakdown in the water treatment plant, a severe pollution event, or the introduction of a novel respiratory virus,
has its impact exponentially amplified.
And the absolute most vulnerable nodes within these megacity networks are the slums.
The reality of rapid urbanization is a devastating triple threat facing urban slum dwellers.
First, you have the classic infectious diseases, cholera, tuberculosis, dengue fever, driven purely by overcrowding, lack of ventilation, and poor sanitation.
Second, you have the sudden onset of non-communicable diseases,
driven by the intense stress of poverty, noise pollution, and the reliance on cheap, highly processed urban diets because fresh food is unavailable or unaffordable.
And third, you have a massive surge in injuries resulting from unregulated traffic, industrial accidents, and interpersonal violence.
Now, the Millennium Development Goals included a target to significantly improve the lives of at least 100 million slum dwellers.
And on paper, it looks like a victory. Data showed that China and India alone lifted well over 100 million people out of slum conditions in a single decade.
That sounds like a massive triumph of economic growth, right?
It is a victory in relative terms, and we should acknowledge the scale of that achievement. But here is the sobering ground-level reality. The absolute number of slum dwellers globally is actually still rising.
Why? Because the sheer velocity of urban migration is dramatically outpacing the capacity of municipal governments to build safe housing, lay down sewage pipes, and establish power grids.
People are moving to the cities faster than the cities can absorb them.
And a massive, often invisible component of that migration is internal migrants.
This is a critical health challenge that completely bypasses traditional health systems. We see profound vulnerability among internal migrants, particularly in China and Southeast Asia.
This isn't people moving to a new city, buying a house, and registering with a local doctor.
No, this is circular migration. People moving from rural provinces to urban manufacturing centers for seasonal work, but they are legally or economically unable to settle permanently.
In China, you have the hukou system, a household registration policy that ties a citizen's access to social services, healthcare, and education to their rural birthplace.
So when they migrate to a megacity for factory work, they're effectively undocumented within their own country.
Because they're transient, socially isolated, and politically excluded, they avoid seeking healthcare until it's an absolute emergency.
Reports continually emphasize that migrant children, adolescent girls, and women in these transient populations are exceptionally vulnerable.
Vulnerable to labor exploitation, sexual violence, and infectious disease outbreaks that go completely untracked by official city data.
Which brings us to a critical inflection point in our analysis. We've talked about the wealth, the demographics, and the urbanization. What does this actually look like in terms of disease?
This is the concept of the double burden of disease.
When we look at general life expectancy in middle-income countries, it largely hovers in that 60s to 70s range.
We also see the expected strong correlations in the data between maternal mortality ratios and child or infant mortality.
If a health system cannot safely deliver a baby, it usually cannot keep a toddler alive either. High maternal mortality predictably tracks with high under-5 mortality.
But the defining epidemiological characteristic, the true signature of a middle-income country, is this double burden.
Okay, let's really unpack this double burden concept because it's the subtitle of our deep dive today, and it is so easily misunderstood.
It is.
A lot of people hear double burden, and they just think it means a country is unlucky enough to have both infectious diseases and non-communicable diseases at the same time. Like, oh, we have malaria cases and we also have heart attacks.
But it's much more insidious and structurally damaging than that, isn't it?
It is entirely structural. It's not a uniform distribution of disease across the population.
The framework we must use here is one of deep socioeconomic fracture.
The double burden means that within a single unified national health system, you have two entirely different epidemiological universes existing side by side.
The poorest 20% of the population, often rural or trapped in urban slums, is still suffering and dying from the classic infectious diseases of poverty.
They're battling tuberculosis, malaria, diarrheal diseases, and high maternal mortality.
Meanwhile, the wealthiest 20% of that same country, who have adopted highly urbanized, sedentary, globalized lifestyles, are developing chronic, non-communicable diseases.
They're dealing with explosive rates of type 2 diabetes, cardiovascular disease, and diet-related cancers.
So imagine you're the Minister of Health. You have a limited, highly constrained annual budget.
You're under massive vocal pressure from the growing, affluent, politically connected urban middle class. They're demanding state-of-the-art cardiology units, specialized oncology centers, and expensive imported biologics.
They vote, they pay taxes, they want first-world health care.
But if you bow to that pressure and divert your limited funds away from the unglamorous rural TB clinics, or you cut the budget for vector control spraying programs in the slums to pay for those MRI machines, what happens?
You trigger a deadly, immediate resurgence of previously contained communicable diseases.
The evidence explicitly warns against this pivot. Diverting limited resources away from basic communicable disease control in lower middle-income countries is a catastrophic policy mistake.
The hard-won successes achieved against TB, HIV, and malaria are not permanent. They require constant maintenance. If you pull the funding, they reverse almost overnight.
So the health system is effectively forced into an agonizing split.
It must simultaneously maintain aggressive, ground-level infectious disease surveillance and control, while also somehow financing and managing a tidal wave of complex, lifelong chronic illnesses.
It's an administrative, logistical, and financial tightrope that many systems simply fall off of.
Let's look closely at the first half of that tightrope, communicable diseases in middle-income countries.
If we rewind to the 1970s, there was this era of incredible, almost naive infectious disease optimism among global health experts.
Smallpox was on the verge of total eradication. Foundational childhood immunizations were successfully scaling up globally, and we had highly effective, cheap TB drugs.
People literally thought we were closing the book on infectious disease entirely. We thought it was a solved problem.
But the brutal reality of the 1980s and 90s completely shattered that illusion.
We saw the explosive emergence of HIV/AIDS, the terrifying rise of multi-drug-resistant TB, and the stark reminder that communicable diseases were still driving massive morbidity.
Even today, in middle-income countries, 4 of the top 10 causes of death are still infectious.
Let's do a deeper dive into the big three, starting with HIV/AIDS.
Globally, there has been a massive, unprecedented expansion of antiretroviral therapy, or ART. Thanks to global funding mechanisms and generic manufacturing, over half of eligible people in low and middle-income countries are now receiving treatment.
This led to a significant 25% decline in new infections globally in the first decade of the 2000s.
But we must differentiate by geography, because the burden is not shared equally. Sub-Saharan Africa bears the absolute brunt of this epidemic.
Half of the top 20 countries for HIV prevalence globally are middle-income countries in Africa. South Africa alone has one of the highest absolute numbers of people living with HIV in the world.
But look at the contrasting patterns. Prevalence dropped significantly in countries like India, Brazil, and Thailand over the same period due to aggressive, targeted public health interventions.
Yet in Russia, estimated prevalence actually increased dramatically, jumping from 0.6% to 1.0%.
Again, this highlights that economic growth does not automatically confer biological immunity.
The existing healthcare structure, the willingness to engage marginalized populations like injecting drug users, and the political response dictate the clinical outcome.
And then there's tuberculosis, which remains an absolute juggernaut. TB accounts for over 1 million deaths annually.
Now, there have been massive global successes with the DOTS strategy. Directly observed therapy, short course. It's cheap, it's effective if followed.
Global incidence actually peaked around 2004 and has been slowly declining in rate, and treatment success rates are hitting their targets in many regions.
But here is the statistical trap that policymakers fall into. Because population growth is so rapid in massive middle-income countries like India and China, the absolute number of TB deaths continues to rise, even as the per capita rate falls.
And crucially, 95% of all TB deaths globally occur in low and middle-income countries.
And the most terrifying development with TB, the thing that keeps epidemiologists awake at night, is drug resistance.
Let's return to Russia because they face a massive hurdle here. Russia has an extraordinarily high rate of multi-drug-resistant TB, or MDR TB.
Historically, it has hit 13%, which is among the highest rates globally.
Let's explain why this is so devastating. Standard TB treatment involves a few months of relatively cheap oral pills.
When TB becomes resistant to the two most powerful first-line drugs, usually due to interrupted treatments, poor drug quality, or spread within prison populations, the treatment paradigm shifts entirely.
You go from cheap pills to years of toxic, incredibly expensive second-line injectables.
These drugs have severe debilitating side effects like permanent hearing loss, and they have significantly lower cure rates.
Several heavily burdened middle-income countries, including Russia, China, and India, are battling significant MDR-TB rates.
It represents a catastrophic failure of basic health system delivery and medication adherence protocols, and it transfers a curable disease into an expensive lethal crisis.
Finally, let's look at malaria. Billions of people are at risk globally. We've seen undeniably great progress with simple interventions like long-lasting insecticide-treated bed nets and the rollout of rapid diagnostic testing.
The data differentiates between countries in the elimination phase, where they are actively trying to wipe it out completely, versus the pre-elimination phase.
As a group, middle-income countries are showing significant progress, with many reporting steep decreases in cases.
But there is a massive red flag in the epidemiology. Where did artemisinin-resistant Plasmodium falciparum malaria recently emerge? Right on the border between Thailand, which is an upper-middle-income country, and Cambodia.
This is a critical geographical point that demands attention. Artemisinin-based combination therapies, or ACTs, are the absolute frontline gold standard defense against malaria globally.
If ACTs fail, we are pushed back into the dark ages of malaria treatment.
The emergence of clinical resistance on the Thai-Cambodian border is terrifying. And what's fascinating, historically, is that this is the exact same geographic pocket, the greater Mekong subregion, where chloroquine resistance first emerged and spread globally decades ago.
It poses an existential threat to global malaria control. It proves that middle-income countries are not just passive recipients of global health interventions from the West.
No, they are the active, dynamic epicenters where the future of global infectious disease will literally be decided.
Which perfectly tees up the topic of emerging and re-emerging infectious diseases. Let's clarify definitions.
An emerging disease is a newly recognized pathogen in humans, something we haven't seen before.
A re-emerging disease is a known pathogen that has suddenly expanded its geographic range, spiked in incidence, or acquired new resistance.
Now, a massive 75% of emerging infectious diseases are zoonotic, meaning they jump from an animal host into a human host.
And why is this zoonotic spillover happening so rapidly and violently in middle-income countries?
Because of rapid economic transition, you have human populations encroaching deeper into wild, untouched territories for logging or mining.
You have the massive scaling up of industrial agriculture pushing livestock against wild animal habitats.
And you have unprecedented urban density to allow the virus to spread once it jumps.
Let's use Southeast Asia as the ultimate clinical case study for this phenomenon. It is a geographic melting pot for every single risk factor driving viral emergence.
We have seen terrifying examples. SARS in 2003, which heavily impacted the economies and health systems of places like Thailand and Indonesia.
The various strains of avian influenza like H5N1, which raised massive, justified pandemic fears.
But perhaps the most striking localized example is the Nipah virus outbreak in Malaysia and Singapore in the late 1990s.
Nipah originated in fruit bats, but it spilled over into humans, specifically because of economic development, the rapid intensification of commercial pig farming that was located too close to natural fruit bat habitats.
The bats dropped infected fruit into the pig pens, the pigs amplified the virus, and the farmers got sick.
Nipah causes severe febrile encephalitis and has a staggering, horrific case fatality rate of around 40%.
It resulted in over 100 deaths and required the military-assisted culling of over 1 million pigs, utterly devastating the local agricultural economy.
So how does a middle-income country, or a megacity, fight something as fast and lethal as Nipah or SARS?
I love the metaphor of surveillance as an early warning radar system. If your radar is turned off, or if you don't even have a radar installed, the missile hits the city before you even know it's in the air.
The revised international health regulations, the IHR, strongly push for what we call syndromic surveillance. This is crucial.
You don't just wait for a slow, centralized laboratory to confirm the genetic sequence of a specific novel virus. That takes too long.
Instead, you continuously monitor the population for spikes in broad syndromes, like acute respiratory distress or unexplained hemorrhagic fevers.
If you catch the syndrome early at the clinic level, you can lock down and contain the threat before it explodes across a megacity and boards an international flight.
Exactly. The speed of the response must match the speed of the transition.
But let's pivot now to the other side of that double burden tightrope. The non-communicable diseases, what I would call the rising silent tide.
The numbers here are overwhelming and largely ignored by historical global health funding. NCDs account for roughly 63% of all global deaths.
And we need to shatter the outdated, pervasive myth that NCDs are exclusively diseases of the rich. They are not.
A staggering 80% of all NCD deaths occur in low and middle-income countries. We are talking primarily about cardiovascular disease, various cancers, chronic respiratory diseases, and diabetes.
And the most tragic, economically devastating differentiation here is the age of onset.
In high-income countries, NCDs generally kill you when you are old. You get a heart attack at 75, you get prostate cancer at 80.
In middle-income countries, NCDs are hitting much, much younger populations. Nearly 30% of NCD deaths in low- and middle-income countries occur in people under the age of 60.
In high-income countries, that number is only 13%. This means you are losing people at the absolute peak of their economic productivity, their peak earning years, and their peak child-rearing years.
It guts families. And what's driving this premature onset?
The core behavioral risk factors associated with transition. Massive increases in tobacco use, drastic drops in physical activity as jobs shift from agriculture to factory or desk work, profoundly unhealthy diets, and increased alcohol consumption.
Let's explore the urbanicity risk factor, because the environment dictates the behavior. Globalization and rapid urbanization fundamentally structurally shift the food environment of a nation.
Traditional agriculture-based diets, which were often highly laborious to prepare but nutritionally balanced, are rapidly replaced by ultra-processed foods that are high in sugar, fat, and salt, but incredibly cheap and calorie-dense.
And this creates a fascinating, dark, inverse relationship regarding socioeconomic status. In countries undergoing rapid transition like Brazil, China, and India, as the gross national product rises, the burden of smoking and obesity is actually shifting toward the lower socioeconomic status groups.
Initially, the wealthy get obese because they can afford the new fast food,
Yeah.
but quickly, the wealthy urban elite pivot. They adopt wellness trends, they buy gym memberships, they eat organic.
Meanwhile, the urban poor are aggressively, systematically targeted by multinational fast food and tobacco marketing. They live in food deserts, and they lack access to safe, green spaces for physical activity.
The poor are trapped in an obesogenic environment.
The economic drag of this shift is mind-boggling. We talked about health creating wealth earlier. Well, disease destroys it.
Macroeconomic analyses show that every 10% rise in NCDs equals a roughly 0.5% drop in annual economic growth.
We are talking billions and billions of dollars in lost GDP in China, Russia, India, and Brazil purely due to preventable heart disease, strokes, and diabetes.
Look at the data from the Thai Ministry of Public Health. Over a 20-year period, they tracked disability-adjusted life years, or dailies.
They saw a clear, wonderful decrease in dailies from infectious diseases and nutritional deficiencies.
But simultaneously, as one graph went down, another skyrocketed. There was a dramatic, almost vertical spike in hospitalizations for diabetes and heart disease over those same 2 decades.
The epidemiological transition isn't theoretical. It is happening in real time, right before our eyes, bankrupting hospital wards.
Which forces us to ask the ultimate systems question. How is the health system adapting to this whiplash?
This brings us to health systems development. Historically, middle-income countries built their health systems to focus on basic, episodic delivery.
They built infrastructures for mass immunization campaigns, localized maternal-child clinics, and short-course infectious disease treatment. You go to the clinic, you get your shot, you go home.
But now, the focus must radically shift to universal health coverage, or UHC, and specifically the concept of financial protection.
Because chronic diseases like diabetes and heart failure require lifelong pharmacological management and incredibly expensive acute interventions, the traditional ways of paying for healthcare in developing nations are fundamentally breaking down.
And the biggest villain in health financing, the absolute destroyer of wealth, is out-of-pocket, or OOP, payments.
When a health system lacks broad risk pooling, meaning you don't have healthy people paying into an insurance system or tax base to subsidize the care of the sick, patients are forced to pay cash directly at the point of service.
Out-of-pocket payments still constitute a massive proportion of health expenditure in middle-income countries.
Why is this so systemically dangerous? Because direct payments strongly, actively deter early preventative treatment.
If a poor rural farmer has to pay out of pocket just for a basic blood pressure check or daily hypertension medication, they simply won't do it.
They will delay seeking care until their untreated hypertension results in a massive, catastrophic stroke.
And when they finally do hit the emergency room, the acute ICU costs completely bankrupt the entire extended family. It is the most inefficient, cruel way to finance health.
To cope with the rising demand for complex care, especially from the newly affluent middle class who are frustrated with underfunded public hospitals, there's been a massive, unregulated boom in the private healthcare sector in these countries.
But we need to apply strict systems thinking to evaluate this trend. There is a pervasive, almost ideological myth that private healthcare is inherently more efficient and clinically effective than public healthcare.
But the data does not support this in emerging economies. A critical systematic review by Basu et al. From 2012 totally debunks this myth in the context of low and middle-income countries.
Yes, the Basu study is fascinating and completely counterintuitive to free market assumptions.
It essentially found that the private clinics will give you a beautiful waiting room, a great cup of coffee, and a shorter wait time. They excel at hospitality.
But clinically, they actually frequently violate evidence-based medical standards of practice and have poorer patient outcomes compared to the public sector.
The private sector in these highly unregulated environments operates with entirely perverse incentives.
Because they are profit-driven and operate on fee-for-service models, they engage in massive overtesting.
They will give you an unnecessary MRI, prescribe unnecessary, expensive branded antibiotics instead of cheap generics, and perform unnecessary cesarean sections, all to drive up the bill.
Great hospitality, terrible, dangerous medicine.
Furthermore, and perhaps most damaging from a systems perspective, the unregulated expansion of the private sector actively drains the public sector.
It is a parasitic relationship in many ways. Public funds, and more importantly, highly trained human resources, are redirected to the private sector.
A top-tier cardiac surgeon whose medical education was heavily subsidized by public taxes at a state university will inevitably leave the crumbling public hospital to work in a lucrative private clinic catering exclusively to the wealthy elite or foreign medical tourists.
This leaves the public sector desperately understaffed, underfunded, and managing the most complex, poorest patients. It exacerbates the fragmentation and deepens the inequality of the entire national system.
Recognizing this massive market failure, some countries are aggressively trying to pivot back. Look at China.
They realized that their earlier shift toward market-based healthcare in the 80s and 90s caused far too much catastrophic, out-of-pocket spending and widespread public anger.
In response, they had to roll out massive state interventions, the new cooperative medical schemes in 2003 for rural populations, and the urban residents' basic medical insurance in 2007, attempting to pull hundreds of millions of people back into a pooled risk system.
So bringing this massive conceptual framework together into our conclusion, the ultimate takeaway from navigating this transition is the absolute non-negotiable necessity of investing in cost-effective public health and prevention.
I like to think of prevention as upstream engineering. If you know a massive flood is coming down the river, you don't just build a bigger, more expensive trauma hospital at the bottom of the valley to treat the drowning victims as they wash up. You go upstream and you build a dam.
For middle-income countries, surviving the economic and health transition without bankrupting the state means deploying expanded, comprehensive vaccinations.
It means implementing systemic, population-level monitoring of behavioral risk factors.
It means having the political courage to legislate heavily against tobacco, alcohol, and ultra-processed junk food, despite corporate pushback.
And it means rolling out massive, cheap NCD screening programs at the community level to intercept diseases like hypertension and diabetes decades before they require catastrophic, bankrupting hospital interventions.
If we connect all of this to the bigger picture, it leads to a final, profound thought on anticipatory governance. Economic transition is like a speeding train.
If a middle-income country builds a health system solely designed to fight the infectious diseases of today, they guarantee they will be crushed by the chronic diseases of tomorrow.
The fundamental policy challenge is this: can an emerging economy successfully learn from history? Can they skip the incredibly painful, expensive, and deadly mistakes made by high-income countries over the last century?
Or is widening health inequality an inescapable mandatory tax on rapid economic growth? Prosperity without deliberate, equitable, anticipatory policy is just a different kind of vulnerability.
That is exactly the kind of provocative policy dilemma we want you to mull over as you step onto the ward or into the clinic this week.
Now, to truly cement the frameworks we've built today, let's run through some rapid, single best answer style recall prompts. Play along with us. I'll ask the question, give you a brief pause to lock in your answer, and then we'll reveal it.
Let's do it.
Question 1. Up to what approximate per capita income level in purchasing power parity does life expectancy show a strong, steep, positive correlation with rising income before the relationship weakens and the curve flattens? Take a moment to lock that in.
Answer: around $4,000.
Question 2. Which international trade agreement severely restricts a middle-income country's ability to manufacture or import affordable generic drugs, a friction most historically evident with HIV antiretrovirals? Take a second.
Answer: the TRIPS Agreement, or Trade-Related Intellectual Property Rights.
Question 3. In middle-income countries facing the double burden of disease, how does the age distribution of non-communicable disease mortality fundamentally differ from high-income countries? Lock your answer in.
Answer: a significantly higher proportion of NCD deaths occur in much younger populations, specifically nearly 30% under the age of 60, compared to roughly 13% in high-income countries.
Question 4. According to systematic reviews, like the BASU 2012 study, comparing private and public healthcare systems in low and middle-income countries, what is the primary clinical drawback of the rapidly expanding private sector? Think about that for a second.
Answer: Private providers more frequently violate evidence-based medical standards of practice, have poorer patient outcomes, and create perverse incentives for massive overtesting, despite offering better hospitality.
Question 5. Where did artemisinin-resistant Plasmodium falciparum malaria recently emerge, posing an existential threat to global malaria control? Pause for a second to lock that in.
Answer: on the border between Thailand and Cambodia.
Excellent.
To deeply consolidate these specific mechanisms and frameworks, I strongly advise you to revisit the sections on economic and health transitions, global trade integration, and health systems development in Chapter 1.4 of the Oxford textbook.
Understanding the precise mechanisms in those sections will absolutely ground your clinical and policy reasoning moving forward.
Here are the details of this episode.
GPH 4. Development of public health and economic transition. The middle-income countries.
Byline:
Between scarcity and prosperity, navigating growth, inequality, and the double burden of disease.